Welcome back, everybody, and today we're going back to the Pitt. This is, well, probably one of the most accurate medical dramas I've come across in recent times. And I picked out one scene, and we're going to watch it and break it down for you. So let's head on down to the Pitt.
I had a tonsillectomy 10 days ago at St. Michael's. Started spitting blood about an hour ago. Good vitals.
Hey, Travis, I'm Dr. Robbie. How much blood?
A couple mouthfuls.
Can you open up for me?
Okay, let's pause there. So this young fella's just had a tonsillectomy some days back, and looks like he started bleeding. And this is quite common. This can happen post tonsillectomy. That's why we usually keep patients in overnight to make sure they don't bleed. So yeah, let's keep watching.
Hey, Whitaker, Jesse. Got a post-tonsillectomy hemorrhage. Nebulize TXA quick as you can. Let's go. Trauma 2.
Well, that's nice. So they're going to nebulize TXA, which is tranexamic acid. So when you nebulize, it's like you give a mist of the drug to breathe it in, to inhale. It's an inhalational form of the medication. And TXA, or tranexamic acid, what it'll do is it'll make sure the blood, once it clots, it doesn't break down too easily. And they can give it inhalationally. We give it IV, intravenously, as well, to help when you have patients who are bleeding, not just from tonsillectomy, from trauma, and any other thing as well. Okay, let's keep watching.
So this can go south pretty quickly. You up for it?
Oh, I can.
Of course you are.
Yeah, it can go south pretty quickly. And I think it's going to go south if this show continues to do what it does.
CBC, BMP, maybe coags.
Very good. We're going to take some blood tests. Why do we do that? One, to see if there's anything wrong with his blood that's preventing his blood from clotting. So they do what's called coags, or coagulation studies. And they study things called the PT, APTT, INR, and things like that. Those specific tests to test different aspects of his blood clotting and platelets as well. And the last thing Dr. Robbie mentioned was a group and save cross match. So they want to know what his blood group is and cross match with whatever blood they got, because he'll probably need a blood transfusion if he bleeds, continues to bleed. Okay, let's keep watching.
8%, BP's 115/80.
Okay, good. 4x4 and a ring forceps. Let's take a look.
Okay, stable. They're gonna have a look inside.
What do you see?
No active bleeding, but there's some white and dark brown stuff where the tonsils used to
Well,
be.
that's good. That's a fibrinous clot. That means the TXA is working.
I'll talk to my attendant. Oh, shit!
Shit indeed.
I need a little help here!
Oh, that's good. That's good. So, rule number one, and our intern friend here is very wise. First thing you do is you call for help. That's what you do. And he's called for help. Let's see what happens now.
Okay, come on, open up.
That's a post-tonsillectomy hemorrhage.
Yank our sponge stick.
He was stable, then it just opened.
So they've turned on the suction.
2 units. Hold blood. Get a second line.
Had an echo come down to see him.
Assholes.
He's tacky to 120. His stats are down to 90%.
Okay.
Oh, that's not good. So I would be more concerned. They're very concerned about the bleeding, which is good. Yeah, they're going to transfuse blood, whatever. But I'll be very concerned about his airway. So he's going to bleed into his mouth, around the opening to his windpipe, his voice box and his windpipe, and it's going to obstruct his airway. He's not going to be able to breathe, and he's essentially going to drown in his own blood, which is horrible. So I don't know. This show, it seems like the emergency room guys do everything. They intubate, they keep them on ventilators, etc. I don't know. In my hospital, it's not like that. So in this kind of situation, they're going to call someone like me, an anesthesiologist or a critical care doctor, and we're going to try and secure the guy's airway, and make sure that we can breathe for him. So it's going to be a crash intubation. And if worse comes to worse, it's going to be what we call front of neck access, which means we're going to make a hole in his neck. It's not essentially, it doesn't have to be a tracheostomy, but it can be just an opening where we can pass a breathing tube and help him breathe. So let's see what happens now.
Get a high flow nasal cannula, 100 of ketamine.
Good. So they're going to try and oxygenate him through the nose with high flow nasal oxygen.
I'm going to try for direct pressure. If head and neck still won't come down, Call Garcia.
So I think they're calling the surgical attending or resident, senior resident.
Ketamine on board to intubate.
That's holding at 97.
Can you get an airway?
Okay, so just nitpicking here. Ketamine, yeah, okay, so they're going to give some ketamine, sedate him to try and intubate him. They haven't given him a muscle relaxant like rocuronium or Sux, but that's just nitpicking. So they got a good fancy glide scope there, which means they can see into his mouth, into his larynx and his voice box, etc. So they can try and pass a tube down there and help him to breathe. But I think he's bleeding a lot, so they've got suction. They're trying to suction all the blood out. Well, let's see how successful they are.
Let's lie him down. Keep pressure on the scab. Nothing but blood.
Nothing but blood.
That's 94.
Not sure we have
It's okay.
tube with the sponge stick.
If I pull out, there's gonna be even more blood.
Doesn't look like you secured that
We're
airway.
working on it.
Bougie.
Open a crike tray and prep the neck.
Yeah, I think so. You're gonna have to plan ahead for any eventuality. So I think the surgical is very good. Not many attending surgeons would do a front of neck access. This is usually the anesthesiologist remit, but anyway, it looks like they don't have any anesthesiologists in the Pitt, which is just sad, or they don't need them, which would be really great. If I don't get called to the emergency department all the time for this sort of thing. But anyway, so they're going to try and pass what's called a bougie, which is a long, flexible rubber tube. They're going to see if they can pass it approximately where the opening to his windpipe is. And once that long, flexible rubber tube is in place, what they'll do is they'll railroad, or what's called railroading, the tube over the bougie. So the tube will essentially follow the bougie into the opening, and that's how it usually works. But it's kind of hit and miss if you can't see the opening into the voice box. Let's see if they manage to do it.
Hold on. I'm going in blind with the bougie. I might be able to feel the tracheal rings.
And I might have a three-way with Madonna. Move.
Did I hear a three-way with Madonna? A sweet child of mine. This is not 1986. Have you seen what Madonna looks like? I'd rather have a three-way with a Sideshow Bob and groundskeeper Willie. But yeah, anyway, sorry, got sidetracked. So, yeah, so he's going to pass the bougie in blindly into this guy's mouth and hopefully into his trachea or his windpipe. And he said he could feel it. So it's very specific, and it's a really good detail. So you can, when you pass a bougie in, let's say you get it into his food pipe, his esophagus, you get a distinct feeling. But if you pass it into the windpipe, it's got the trachea's got these rings, the cartilages, so it's like ribbed. And you get a bumpity bump feeling when you pass the bougie in, and it's very good. It's a tiny detail. It's not even a second that they mention it, but it's really good. It adds to the authenticity. And yeah, but I was distracted by the Madonna three-way. And anyway, let's go. Let's keep watching.
Not happening. Pressure.
Make room for the grown-ups.
Okay, hold on. We can try retrograde intubation.
Oh.
No obstruction. We just can't see what we're doing, so we take a needle.
Oh, very good. So that's a retrograde intubation. We'll see if they do it, and then I'll try and get an image up and try and show it to you. So they're gonna try and possibly pass a wire through this guy's. We'll see how they do it, and then I'll explain it to you later.
And we put it in the cricothyroid, the guide wire up and out the mouth, and we slide an ET tube up over the wire.
Never seen one before.
So that's 90.
No time to play MacGyver with this kid. Time to crike.
That'd be quick.
Sats are 90, that's fine. Okay. So that's a needle they're passing into his trachea, or into his cricothyroid, sorry. And he's passing a guide wire into the needle, into the trachea. Now that's a little flexible wire with a sort of a curled end. It's going to hopefully
More suction.
come out through the mouth, or at least will be.
Feeling in there. It's gotta be there somewhere.
The guy at the top end is going to try and grab onto that wire.
89.
Guys, this is not working.
So that's 89, that's fine.
Arrest?
Oh my God.
So The guy at the top end's got either some sort of forceps that he's going to try and grab the end of that wire that's coming through the neck and try and pull it out, and then they'll use that wire to guide the endotracheal tube into the larynx. Just kind of what they tried to do with the bougie, but the bougie didn't go in the right place, so they're going from bottom to top, retrograde. So it's a retrograde intubation. It's very cool. We don't usually do it. I mean, if you can get a needle into the front of the neck, we just pass a tube into the neck directly. So it'd be sort of what we call a scalpel bougie technique, or just a front of neck access. This is a bit old school. I haven't seen many. I don't think I can remember doing one recently or at all. But yeah, it's pretty cool. It's definitely very exciting. Let's see if they manage to pull it off.
There's another patient.
Stop, Whitaker. He's got this.
Sat's down to 87.
Okay, I'm gonna redirect the wire.
Sats 87. I'll tell you at the end of the video how the lowest Sats I've seen.
86.
Will shock you.
You got this.
84. We need to bag him.
Still not seeing it. Suctioning like crazy.
Okay, we're done playing doctor. Lose the wire. I'm cracking this kid.
All right, we tried. I'm sorry. No, wait. I've got it.
Oh, Scott. There you go. That's it. Oh,
Still don't
that's
have an
really
airway.
good.
Did I just put in place the two
So
past the-
they're putting the tube
past the tube?
over the wire. So the wire's going inside the tube.
Hang on to that wire. Do not let go of that wire.
Yeah, never let go of your guide wire. It's rule number 1
Yeah,
of
slide so you get past the-
Anesthesiology Fight Club.
Yeah, I feel you have the trachea.
25 centimeters at the lips.
That ought to do it.
25, that's a bit
Wire,
deep.
bag him.
Anyway,
Balloons up.
so and they pull the wire out.
Yellow on CO2. That's good.
That is very good.
Very good. Very
Rest
good.
bilaterally.
Dr.
Sats
Robbie,
coming up.
please turn your
90,
stat the right way.
92.
Guess you're gonna have to save that scalpel for another day.
You guys got lucky.
No, we got skills, baby. We got skills. Keep gauze on the car.
A copy.
Oh, that's very nice. That happened. They used the wire, and we love guide wires. We do a lot of techniques, a lot of procedures using the wire. It's called a Seldinger technique. Putting lines in chest drains, etc. And this is one of the scenarios where you can use that. Passing the wire. Let me try and get an image up, and I'll try and explain it to you. So okay, so here we go. This is our lovely subject. They're using a direct laryngoscope and not the glide scope, but it doesn't make a big difference. So in an ideal situation, I'll show you. So this is your trachea over here, and it divides into left and right bronchi that go to left and right lungs. This pathway is your esophagus, or your food pipe. So your windpipe and your food pipe, and we want to put this tube into the windpipe so we can put in oxygen and take out the carbon dioxide, etc., and help the patient breathe. Now the problem with this guy is he is bleeding from somewhere around here, and there's a lot of blood collecting up. So we cannot see where we're putting the tube. And even if we put a bougie, which is a long rubber tube, it's most probably going to end up in the food pipe because of the curvature here. Okay. So what they did was they stuck a needle somewhere around here. Okay, so let's just say there's a needle. If we take a cross section of the needle, oh yeah, my paint skills are shite. Okay, and then they pass a wire. Let's say this green line is a wire. This wire should naturally tend to curve, and then they can see it through the opening of the mouth, past all the blood here, and they can pull the wire out, okay, or at least upwards here. Then pass the tube, the endotracheal tube, over the wire, and it should follow the path of the wire up to here. And once it's sort of fairly a decent amount, they said 25 centimeters, which is quite a lot. It's usually going to end up in one of the bronchi, but they pass it far enough, and then they just pull this end of the wire out, and hey presto, that's your retrograde intubation. They'll pull this needle out as well. That's pretty cool. Yeah, and his sats started dropping, and don't worry about that too much, because I see them drop all the time, especially when we're intubating patients who are obese are quite, overweight. Their stomachs, etc., their abdomen is sort of pressing up on their lungs. They don't have much reserve oxygen capacity. As soon as you knock them out and they stop breathing on their own, their sats plummet. And I've seen them go as low as, in an emergency situation, I've seen them go as low as 30 or 40, even lower, and people still survive. But yeah, that's a different story. But this was a really good scene from a technical standpoint, and even special effects, guys. It's all practical effects, and it looks really good, indistinguishable from reality. To be fair, acting was great as well. And hopefully I'll probably do a full episode if I can, if I have the time. I just going through most of the scenes, and then I saw this. I thought I'd throw my 2 cents in. But anyway, all right, everybody. We'll catch you again another time. Stay safe, stay healthy, and see you again. Bye.